Test 1, 2, 3. We're going to see how this sounds. Speaking. So by conducting your general impression of that pediatric patient, you're going to use the infamous pediatric assessment triangle. So we're starting with appearance. Do they have any kind of abnormal tone? Are the babies holding their arms as they normally do? Is everything sprawled out? Are they lethargic and just flaccid? What is their interactive ability? Are they looking at you? Are they just having that million-mile stare, or unresponsive? Consolability, if they're crying, is mom able to calm them down, or are they just being hysterical about everything? Are they having any kind of abnormal look, gaze, speech, or cry? Are they having that million-mile stare? Remember with those little kids looking at the luster in their eyes. Do they have this big, bright, white parts of their eye, or are they yellowed and just dull, lacking have that luster, dull appearance? Do they look glossy and shiny, or do they look flattened? With that speech and cry, any kind of crazy sounds? Are they? Does their cry sound painful? Is it hoarse? Is it raspy? Those kind of things can allude you to upper airway things as well. Next, in that work of breathing, do you hear any kind of crazy sounds with that breathing, or they're crying? Do they have any kind of abnormal positioning? Are they doing the head bobbing? Do they have any kind of muscular retractions? The sternomasculoid muscles from their neck to their jaw, are they really using those to bob their head? Are they having those intercostal muscle retractions? Any kind of nasal flaring, or the guppy breathing, or worst case, apnea? And then with circulation in the skin, checking the pallor. Is that skin pale? Do they have any mottling? So that red splotchy looking thing, to where their skin isn't just red throughout, it just almost has like a cheetah look appearance to it, where it's red and splotchy. Or cyanosis. Is their skin looking blued? Then going on into your secondary assessment. So this little range here is straight out of the West Virginia protocols of what normal vital signs should be on kids. So as you get older, your heart rate's slowing down a little bit, your respiratory rate's slowing down a little bit, but your blood pressure's increasing. And in most research, it shows that blood pressures for kids under the age of 3 aren't that reliable. So we're using blood pressures to assess perfusion, but that's not always the best evaluation. So in kids, we're going to do some capillary refill. As little babies, how big are their fingernail beds? They're itty bitty, sometimes smaller than a pencil eraser. So it's hard to really assess good capillary refill there. But if you know basic anatomy, there's capillaries everywhere in our body. So go to those distal extremities, out to their wrists or their ankles where there's some surface area bigger than your thumb, and push down. And then that capillary refill should be less than 2 seconds. If it's taken more than 2 seconds for that skin to turn back to pink, they are hypoperfusing. So shock is just simply a state of hypoperfusion. So looking at those vital signs, if you see any of those heart rate changes any higher, respiratory rates any higher, those are those first indications of shock or hypoperfusion and poor capillary refill. So with that assessment, if you're seeing those increased heart rates out of that normal range, if you're seeing hypoperfusion by poor capillary refill, that ties into that cardiac output too. So this little diagram here is out of PHTLS, giving that correlation of about where you're going to really start to see those changes in cardiac output. Now we know that kids will compensate much longer than adults do. So those adults, they can end up starting to lose some of their blood volume and lose their blood pressure around 15% of their blood loss. But with kids, you may not necessarily see any of those crazy perfusion changes until you're upwards of 30+ % of their blood volume. Okay, so in kids, that might only be a liter of fluid that's in them anyway. So you lose 200-300 cc's of fluid. not going to phase an adult, but that could be difference between life and death to a kid. So when you're looking at this chart here, you're seeing the heart rate increasing. Something that should kind of be tied into this is that respiratory rate. That's that first sign of compensation in adults and kids, is that increase in heart rate and increase in respiratory rate. As the heart's starting to work harder, trying to maintain that cardiac output, the oxygen demand is going to increase, so that respiratory rate is going to increase, trying to bring that oxygen. And as that body's starting to lack oxygen from hypoperfusing, it's going to slowly start to become acidotic. And we know from our medical patients that the acidotic patients will hyperventilate or increase their respiratory rate and be tachypnic, trying to blow off all that acidity in their body. So if you're seeing that tachypnea and tachycardia sustaining those kids, and then those early signs of poor capillary refill, so and checking that out at the extremities, not on the core. So if you're having poor capillary refill in a kid's chest, that's terrible. Really, really bad, because the body shunts that blood back to the core, trying to perfuse all those vital organs. So check at capillary refill, backs of the palms, tops of the feet, and the wrists, the ankles. And as you see closer and closer to the body, as that capillary refill gets slower and slower, closer to the core, the worse their perfusion status is. And then in that secondary assessment, you need to do your detective work of figuring out why this kid is in a state that they're in. So checking for those signs and symptoms of shock and trying to evaluate why they are in shock. So could it be due to hypovolemia? Has a kid been experiencing diarrhea, vomiting? Are they just being malnutritioned? And that doesn't mean that it's the parents' fault. If the kids are just having poor fluid intake or food intake, that can make them hypovolemic. Or is it hemorrhage due to trauma? Could it be distributive, that loss of vascular tone, such as from anaphylaxis? Do they have a fever, and are they modeling from signs of infection and sepsis, causing that high levels of acid, causing those vessels to lose their ability to maintain their structure, causing them to dilate? Or could it be from toxins, some kind of overdose? Or the least likely one to see is that cardiogenic shock in kids. And mostly always that's from congenital defects, that the child has a known history of heart disease, some kind of abnormality that's been known since birth. So your primary interventions are going to be, as they are in every shock patient, keep the patient warm. In shock, we know that the body has to maintain a certain level of temperature for proper blood circulation, for proper metabolism, or that patient's going to become more acidic, go further into shock, just furthering that death cascade. So wrap those little babies up in a burrito, layer the blankets in them, keep them nice and warm. Okay, those kids are basically a really big house with an inefficient furnace. They have wild extremes temperature changes that their body can't compensate to. So that's what those kids, when they become really fevered, they seize because their body just can't regulate that well. And kids can become hypothermic extremely easily because they've only got a small amount of fluid in their body to circulate to help try to cool it down, and that little furnace is having to go into overdrive trying to regulate that temperature. So keep that kid warm, wrap them up in multiple layers, turn the heat on an ambulance, keep them warm. Then give the kid some oxygen. Now be careful with the oxygen, like it's pictured here. If this is a really new baby, a neonate, we don't want to blow oxygen in neonate's eyes. Okay, so we give them some blow-by oxygen. Those kids are gonna need that oxygen. And in more in the medical kind of patients, we consider maintain the oxygen saturation of 94 to 99% in the adult patients. And little kids, that's not as much of a concern, especially if they're in shock. They're gonna need that oxygen. And remember, those kids got that big old floppy cow tongue, and they got that big bobblehead, so airway positioning is crucial. Pad under their shoulders, get that torso elevated, get the head back in a natural sniffing position so they can maintain their own patent airway. After those primary interventions, which is your BLS interventions, because remember, BLS before ALS, generally always. So with those ALS interventions are going to come some more in-depth assessments. So in terms of hypovolemic shock, which is going to be that loss of volume, that can be caused from that diarrhea, vomiting, malnutrition, hemorrhage. So signs and symptoms you're going to look for is that poor skin turgor, that skin tugging test. That's going to be more along the lines of that patient who's had not as much of an acute onset, maybe a little bit more chronic, possibly over a couple periods of days. So you pinch that skin, and kind of in terms of that skin or the capillary refill, if the skin doesn't go back to its natural position, the patient is severely dehydrated. So poor skin turgor is going to be a sign of pretty significant dehydration. They can have also the some lack of tears, those sunken fontanelles. That's before about 9 months. So at about 9 months, closer to a year, those fontanelles in the skull are coming close. So in those little babies, you'll see those sunken fontanelles from lack of volume. And then your other typical classic signs and symptoms of shock of cool, clammy skin, poor capillary refill greater than 2 seconds, and also some dried membrane. So if that tongue is really dry, kind of cracky, or in their mouth they look like they're not salivating and slobbering like a normal kid should. Treatment for those hypovolemic patients is going to be, first, after you've confirmed that it's probably, definitely, or most likely, or definitively hypovolemic shock. That's definitely a load and go patient. So establish an IV and give it a bolus of 20 per kilo. The same fluid bolus you're going to give to adults, 20 per kilo. If it's later signs of that, make only one attempt. So if they are decompensated and they have all the classic signs and symptoms of shock, of that altered mental status, pale, cool, diaphoretic, only make one attempt on seeing to get that IV or IO, and then rapid transport. So if they're in those dire straits, one IV attempt, get that IO in there because they need replenished quick. Transport. If after that one fluid bolus it's not working, you can repeat that up to a total of 3 boluses, so up to a total of 60 cc's or milliliters per kilo is going to be the max fluid resuscitation you need to. If you can't get them inadequately reperfused with 60 milliliters per kilo, you need to contact your MCP for further orders. In terms of distributive shock, the loss of vascular tone can be from such things as anaphylaxis, sepsis, or overdoses and other toxins. So the signs and symptoms for anaphylaxis: respiratory distress, cool, clammy skin, poor capillary refill greater than 2 seconds, and altered level of consciousness. Signs and symptoms for sepsis is a fever, capillary refill greater than 2 seconds from the hypoperfusion, that change in mental statuses or level of consciousness, and skin mottling, that red splotchiness. So that urticaria for anaphylaxis is going to be more localized, where skin mottling is going to be more completely peripheral throughout almost the entire body can have that skin mottling. With the distributive shock, if you're not able to fix it with 3 doses of 20 per kilo boluses, so if 60 milliliters per kilo is not resolving that hypotension from suspected hypovolemia, contact MCP and get orders for a pressor like dopamine. If it's anaphylaxis related, you're going to go with, if the respiratory distress is in there and all those crazy signs and symptoms of hypoperfusion, respiratory distress, you're going to go immediately with epinephrine 1/1000 intramuscularly. So the cutoff is going to be 66 pounds or 30 kilos. Anything over that is getting the adult dose of 0.3 milligrams IM. If it's less than 66 pounds or 30 kilos, that's 0.15 milligrams intramuscularly. Then follow that up with 1 per kilo IM of Benadryl, up to max dose of 25 milligrams, because the adult dose is 25 milligrams. After that, if there's still some respiratory compromise or still bronchoconstricted, still have wheezing, give them an albuterol treatment, 2.5 milligrams. Remember, albuterol only, no Atrovent for the wee little kids. Now, in terms of cardiogenic shock, that's going to be the most least likely type of shock you're going to see in the field, and those are going to be generally related to congenital heart defects. There's a known history of heart disease in these kids. Their signs and symptoms could vary from heart blocks to just those classic signs and symptoms of shock. Those parents or the care providers are going to be the subject matter expert, so consult with them to see what their history is. Generally, they're going to be the experts and know the kind of treatment that generally resolves any kind of anytime there's an exacerbation of this child's illness. So immediate transport with them, get them to the appropriate facility that can handle those bad pediatric hearts. Give a bolus of only 10 per kilo. Since those little pumps aren't as effective as a normal healthy kiddie pump, half the dose. So give one bolus of 10 per kilo. If that doesn't work, contact medical command, speak to a physician of how to treat that specific disease, which is most likely going to be with a pressor. So in conclusion, as pearls for treatment, simple stuff, same way as adults. Going to keep them warm, layer them up in blankets, keep them warm, turn the heat on the back of the ambulance. Quick assessments and detection, and then quick interventions. So given 20 per kilo, a bolus is up to a dose of 3 of that for 60 milliliters per kilo. If it's cardiogenic shock, you only want to give one bolus of 10 per kilo, and contact MCP for orders or other interventions. Thank you.